Hi, my name is Brittany, and today I will be talking about a case study that covered the effects of decelerated rehabilitation following an anterior cruciate ligament reconstruction on a hyperelastic female adolescent. Typically, an accelerated rehab program is used for the quickest return to pre-injury level, and those success rates have been well documented. Individuals who have general ligamentous hyperelasticity hyperlaxity might present with an increased risk of developing laxity and or instability when they have undergone an ACL reconstruction, but there's lack of evidence to support that has been reported. The sole focus of this case study is to examine the effects of a conservative treatment versus an accelerated treatment with a female athlete who has hyperelastic tendencies. Ligamentous hyperelasticity confirmed by the following tests of hyperextension of the knees, the elbows, hyperextension of the metacarpophalangeal joints of the hand, the ability to bring the thumb to the volar surface of the forearm, and the ability to flex spine so that palms touch the floor with knees in full extension. All of those were performed to identify the athlete being hyperelastic, and having 3 or more of those characteristics deems you having hypermobility syndrome. And in this situation, this female athlete had all 5 characteristics. All right, now to the evaluation and analysis of the case study. Arthrokinematics measurements used by the KT2000, range of motion, biodex strength and proprioception evaluations, along with balance evaluations were used. A single leg hop functional evaluation was also used, and also patient questionnaire subjective forms. Rehabilitation. So in this study, they used 6 principles, and those principles included healing tissue should never be overstressed. Deleterious effects of immobilization must be prevented. Patient must demonstrate criteria to progress from one stage to the next. The rehab program must be based on current clinical and research data. The rehab program should be individualized, of course. And final principle is the success is related to the team effort of the physician, the therapist, the patient, all working together with effective communication to achieve the best outcomes. Along with this, the length of the second phase changes between a decelerated and an accelerated program. It emphasized a prolonged period of maximum graft protection, so that second length of protecting that graft was longer than it would be in a typical accelerated program. Early rehab, included gentle patellar mobs, prone passive knee extension, active knee flexion, hamstring stretching, ankle muscle strengthening for 3 sets of 10 each, progressing as the patient could tolerate. Including straight leg raise in supine, especially when extension lag was not noted anymore. And patient was only able to progress as long as that extension lag did not exist. Functional exercises were added to the program when manual muscle testing was deemed more than fair in the quad, and the hamstring strength without effusion. That is when they were able to progress to functional exercises. Light activity based on post-op testing of quad strength had to be greater than 70% of the uninvolved extremity. And the return to activity prompted by week 24 post-op testing, in which range of motion was maintained, along with knee stability, proprioception, and balance equivalent to uninvolved extremity. Now on to clinical application. Establishments have been attempted to be made to determine the causal relationship between generalized ligamentous laxity, hypermobility, and other pathologies. Like degenerative joint disease and patellar, ankle, and hip dislocations. A patellar tendon graft typically goes through a ligamentization or transformation, meaning that the cross links increase and maximize fibroblastic activity around the 6-month post-op. This helps to justify the hyperelasticity may not have the ability to produce the amount of cross links needed to allow the patellar graft to be structurally sound, unless a prolonged period is allotted. Not much is known if the graft can withstand loads during the healing and maturation stage. An accelerated rehab may not be appropriate with a hyperelastic patient due to that factor. And a decelerated program might yield better functional results without compromising the integrity of the tissue and the overall stability of the knee. This alludes to reconstruction of the ACL that does not have the appropriate rehab program may potentially fail, along with the compliance and motivation of the patient if they are hyperelastic.